This has historically been an area where communications processes from the primary care physician or the specialist physician with which the patient engages prior to their acute experience, and then there's an acute experience, and then in many, many cases there's also a post-acute experience. You know, one of the issues historically with the way that has worked has been the disjointed or the siloed nature of those types of care or those destinations. So if you think about historically, you know, maybe you've had an aunt or an uncle or a grandfather or a mother or a father or a grandmother who had to engage in the healthcare ecosystem, right? And that typically starts with that primary care doc, or maybe it's a specialist doc, and then that physician says, you know, okay, you know, Ms. Smith, this is what's going on with you. You're going to need this type of care at the hospital. So when the patient moved from that, either that primary care doc or that specialist into their acute experience, right, they've entered the big box, right? They've entered the big STAC box. And when they're in that box, well, they're going to be rounded on or attended by what's called a hospitalist. And a hospitalist is just that. It's a physician who is specially trained on managing the conditions of patients when they are in acute care. Now that hospitalist, while he or she is providing care for that patient, depending on patient conditions, may order specialists. So you could have a neurology consult, you could have a cardiology consult, you could have an infectious disease consult. So you have at least a hospitalist, but probably a hospitalist as well as other specialist physicians who interact and provide care for the patient while they're in the acute care space. So patient has whatever amount of time, you know, number of days they're in acute, and then they transition into their post-acute. Let's assume in this case that the patient comes to a place like Baybrook Village where we are today. So when that patient transitions from acute into post-acute, what happens is all the doctors change. So when they get here, they will be the attending or the rounding physician here is what we call a sniffist or a transitionalist. Now that doc really profiles here, just like the hospitalist profiles within the four walls of the hospital. So he or she has the responsibility for overseeing that patient's care, working with our clinical team here, our director of nursing, our other nurses, our rehab team. In many cases with certain patients that are in rehab, we have a physical medicine physician that will consult. That doc could also call in other specialists, just like in the hospital walls, right? The doc could call in as needed, as clinically indicated, cardiology consult, neurology consult, infectious disease, depending on what the patient's condition is. So at this point, you know, think about this. You've had your PCP or your specialist. You've had another set of doctors. Maybe your specialist followed you into the hospital. Maybe he or she didn't. And now you're out here in the post-acute space. A historical challenge with that has been the siloed nature of those buckets of care. There is a substantial movement afoot in our business to try to better integrate and better communicate across those silos of care. So some of the things that we've done to try to improve that coordination of care and improve that communications process is, one, when we vet and onboard a SNFist or a transitionalist to work in one of our transitional care centers, we look to find physicians who have a link into that hospitalist group. In fact, best case scenario is we have a SNFist who's also a hospitalist. And so when the patient is referred, let's just say from, you know, Baylor McKinney down the street here, that hospitalist is referring the patient to Baybrook, but is also referring the patient to one of his colleagues. So there's important knowledge transfer that occurs as a result of those two physicians' connection. And that knowledge transfer is what really helps to coordinate the care, really helps us to drive improved clinical outcomes, really helps us to drive a better patient experience in the post-acute space, helps us to better manage cost and time that the patient is in the inpatient part of their care program. We are piloting up there, or have piloted and have actually morphed it into a full-blown program, the Spectrum model. And up there we have, in Oklahoma City and Norman, we have a physician, Dr. Raju, who works with us. And so the way the Spectrum model works is Dr. Raju has a nurse practitioner, high-level clinician, who rounds in the transitional care setting along with him. So you really increase the bandwidth of the physician by picking a highly qualified mid-level, like a nurse practitioner, where Dr. Raju is rounding in the building, 2 or 3 days a week. We add another 1 or 2 days a week, depending on the number of patients in the building at a particular time with certain conditions, by having that nurse practitioner rounding as well.